Welcome to the second day of our bleeding disorders conference that we're doing, medical conference for all of our healthcare, our patients, our members, our families, our caregivers. We got a great morning packed here. We thank our doctors from yesterday that we had all about our HTCs and about the chapter. I won't do that again, but if you'll bear with me, just a few quick questions and statements just to let you know a little bit about us. So my name is Sue Martin. I'm the Executive Director of Hemophilia South Carolina, soon to be known as the Bleeding Disorders Association of South Carolina. You see that in our name. We are still, waiting for our tax returns. And once everything comes through and we are officially 100% Bleeding Disorders Association of South Carolina, we will start using that name exclusively. I'm also a mother of children with hemophilia, so this is very personal to me. So I'm excited that we are able to provide this opportunity for you to learn. I'm with Greg today, who's my host. He's the communications coordinator at our chapter. So he'll be helping me today doing this presentation and providing this education to you all. I would like to give a huge shout out to our sponsors. We have Sparks Therapeutics, Genentech, Takeda, Hemophilia Federation of America is bringing us our presenters, and to Hemophilia Foundation of Greater Florida with my best friend, Fran. Thank you, Fran, for the opportunity to bring in Dr. Davis with us today in our CU credit. So she's just a wonderful individual. So thank you, Fran, for that. And then I'm just going to go ahead and get started since we have a lot going on. We'll be taking a 10-minute break in between each one of our presenters. So we've got about an hour here with Dr. Davis out of Miami. So I'm just going to turn it over to her. I'm going to take down my slide. Greg's going to bring up his presentation, her presentation, and we'll get started. And also, if you have questions, put them in the chat. And then we'll watch the chat. And Greg, you're going to have to do your full. There you go. Put it in the chat, and then we'll answer the questions. If you don't see that we're answering your question or we didn't see it, go ahead and raise your hand on your where is it? On your little reactions. You can do one of these, and then we'll get to you. So we'll kind of take some as we go, and we'll take some at the end. But on that note, I'd like to turn this over to Dr. Davis. Thank you so much for being with us.
Well, thank you for the invitation, and thank you to everybody who got up early or delayed doing your usual Saturday things. This talk started a long time ago, probably 15, 20 years ago, when I realized that even in our institution, with an HTC, our families were not getting the care that they needed when they came into the emergency room, certainly when they went out into the community, if they were traveling, or local ERs. And what this has evolved into, as you can see, there are a number of physicians in Florida now who are presenting this where the need arises. But what this presentation does is, for those who are in the healthcare field, it's an update, and it's sort of a global update in terms of where things are. I cannot tell you how many times I hear from nurses, nurse practitioners, physicians, I never knew that. This is totally different than what I learned in nursing school or medical school. And for our families, some of this may be a repeat. Many of you probably could give this talk, but hopefully it will give you some additional insights, as well as some tools for you to advocate for yourself, your child, your spouse, your brother, if you do find yourself away from your HTC in an environment, an ER, an urgent care, where people may not be familiar. So that being said, we're going to be driving this remotely. So next slide, please. Just to reiterate, this is being supported by the Hemophilia Foundation of Greater Florida. Thank you, Fran Haynes. I add my thanks to it. And there are CME and CEU credits, which are being given by the Dana Miller Foundation for those in the audience who would like an hour CME CEU. To that end, there is going to be, at the end of the presentation, as well as in the chat box, a link to an evaluation Now, this does a few things. If you want CME CEU credits, there's a way of indicating that through there. But for members of the audience who might not, this is grant supported. And any feedback that you can provide to us through this evaluation will be very helpful for moving forward. Are there things we should change? Are there things you didn't like? Are there things you would have liked more of? And it would be greatly appreciated. Next slide. And again, this is just some more basic information in terms of the Hemophilia Foundation. I do have some disclosures. I serve as a consultant for Spark, for BioMarin, Genentech, Novo Nordisk, CSL Behring, and Takeda. Next slide. Okay, so I'm a pediatrician by training, and clearly the best way for us as healthcare providers to engage with our families and to make sure that everybody's on the same page is to talk and to make sure that we're not just leaving families sitting there nodding their heads because that's what we're saying. So I always start my conversations, particularly with a new consultation or a new family, by explaining what happens when we're bleeding. And the process by which we control bleeding or stop bleeding is called hemostasis. And the way I explain it to families, and again, bear with me, I am a pediatrician, is I say there are three things that happen all at the same time. And it doesn't matter if you're bleeding because you're a kid and you pick your nose, although we know that never happens, or you fell down, or you're having surgery, or you're having a menstrual period. The first thing that happens is the blood vessel tries to squeeze shut on its own. That doesn't really do much, but it does start the process going. Then there are platelets, little sticky pieces of cells like Velcro that are directed to go to the place where the blood vessel is leaking and basically make a platelet band-aid. Now, these platelets are like Velcro. And if any of you are bored during the presentation and you're wearing something with Velcro, you can play with it, right? Open it, close it. But if you look really closely, you'll see that the little hairs or the little projections on the Velcro fit in between each other, and there are spaces. Well, that's what that platelet band-aid or plug looks like. There are spaces. And if something doesn't happen to fill in those spaces, that platelet plug will fall apart in a relatively short time. So that bleeding, if it was controlled, will start up again, or if it really was never controlled, it'll just keep going. So enter the clotting cascade. And we can do the next slide. Okay. And this is, again, talking about what the platelets do, right? The platelets have to stick to the blood vessel wall, and then they have to heap themselves up on top of it. Next slide. And this just shows you that response to vascular injury. So you have at the top left, you have the break in the layer, the endothelial layer, the lining. And then the middle slide shows you those little yellow platelets, and they're kind of sticking there. And then at the end, they're all heaped up and we're making a clot. Now, if you take a look at the electron micrograph, the photo, that shows you an activated platelet within the fibrin clot. So where do we get the fibrin from? The fibrin is that mesh that fills in those gaps. Next slide. And this is the clotting cascade, right? This is for those of you in the audience who have or are living with factor deficiency challenges, factor 8 deficiency, factor 9 deficiency. This is where it happens. So as I explain to families, I want you to close your eyes and I want you to think about the guy who sets up the dominoes in the attic and goes all the way to the basement. You guys have basements in South Carolina? We don't have basements in South Florida because we'd all be flooded out. But we do have multi-story homes, and everybody kind of gets it, and everybody's seen it, right? Either late night TV or YouTube, where you knock one over and they all fall down. Well, this is what this clotting cascade is like. One of these proteins in the course of this whole thing where the blood vessel's squeezing, the platelets are moving, one of these proteins gets turned on or activated, and it turns on the second, the third, the fourth, the fifth, and it's like knocking over that line of dominoes. And at the end of it, which takes about 30 to 35 seconds, at the end of it, there is the formation of something called fibrin monomer. And this is a biological glue or a cement that fills in the gaps between the Velcro platelets and makes that clot tight. Now, I ask my families, including the kids who are old enough to have this kind of a visual, I want you to think of that line of dominoes. And I want you now, you've knocked over the first one and there they all go. And I want you to take one out. What happens? And even the littlest ones, the 3s, the 4s, I mean, everybody's so tech savvy these days, right? So they'll say it stops. That's right. The activation cascade stops and you never reach that end. You never knock over that last domino to make the fibrin. And that's what we're talking about when I am concerned that you, your son, whoever, has a factor deficiency. You're missing a domino, or you have a short domino or a skinny domino, and it just doesn't have the wherewithal or the oomph to get to that end. Now, on either side, you see that there are 3 different parts of this coagulation cascade. Not going to go into these in great detail. However, you are probably very familiar with these general screening tests of the efficacy and the integrity of the clotting cascade. And one of them is the PT, right, which is shown on the right-hand side. And that is what really reflects the integrity, the activity of clotting factor 7. So for patients with factor 7 deficiency, your PT is most likely going to be prolonged. And it depends on the lab, and it's usually 9 to 14 seconds. Every lab is different. Flip to the other side, the APTT. Many of you who have hemophilia A or B are very familiar with this, because this is the part of the clotting cascade that involves clotting factors 8 and 9. So if you have hemophilia A or hemophilia B, your pro time, your PT is going to be normal because there's nothing wrong with your factor 7. Your platelets are going to be fine, but your PTT is going to be prolonged. And again, normal values depend on the lab and the reagents. And then these 2 pathways come together and they form the common pathway, which is factors 10, 5, 2, and 1, which is fibrinogen. And that's measured by the thrombin time. So if you're a patient who has a fibrinogen deficiency or a factor 10 deficiency, you're going to actually have a prolonged PT and a prolonged PTT because everything funnels in there, as well as a prolonged thrombin time. And for those patients and families living with factor 13 deficiency, you actually pose a diagnostic challenge because you may have bleeding symptoms. Factor 13 is important for toughening up that fibrin clot. So the fibrin's been made, it's filled in the gaps, but there's an extra step to make it even more robust. And that step, that cross-linking, is responsibility of clotting factor 13, and that occurs separate from this domino effect. So patients with factor 13 deficiency will have everything normal on these screening tests, but yet they're going to be bleeding, and that requires additional evaluation. Next slide. And nothing is ever simple, right? So now we've made our clot. That's great, right? But we don't want clots to hang around too long. So there's a balance between the clot making proteins, procoagulants, and the clot busting proteins, or the anticoagulants, because we know if clots hang around too long, they can grow, they can break off, we can have problems. Many of you may have heard of VTEs, DVTs, pulmonary emboli. So there is a very delicate balance. Next slide. And this clot busting system is called the fibrinolytic system, right? Because it's breaking down fibrin. Lytic is breaking down. And this just shows you what actually happens within a clot. Once the clot is there, then you have all this other stuff going on to break it down. And many of you may have had the opportunity or have been prescribed something like Amicar or tranexamic acid as a way of helping control bleeding in the nose, in the mouth, menstrual bleeding. Well, this is where those things work. Those are called antifibrinolytics, and they actually interfere with this process so that the clot, which has been formed in your nose, in your mouth, in your GI tract, you know, in your uterus, maintains itself and doesn't break down so fast. Next slide. Okay, So this is clearly preaching to the choir here, just to give a nod to it. Hemophilia A and hemophilia B are both X-linked recessive disorders. Hemophilia A is a deficiency of clotting factor 8, 1 in 5,000 live male births. Hemophilia B, factor 9 deficiency, also known as Christmas disease, 1 in every 30,000 live male births. This is an equal opportunity disorder. It doesn't matter what country you're in. It doesn't matter what church or synagogue you go to. It is what it is. And this incidence is pretty consistent. We used to think that they were the same. Just the protein was different, that everything about it was the same. But we have learned that there are differences between the biology and the physiology of factor 9 as opposed to factor 8. And some of this will get discussed a little bit more towards the end. We grade the hemophilias by how much clotting factor is being produced. So a lot of the information out there, a lot of the efforts have been focused on those patients who do not produce any clotting factor 8 or 9. Those are our severe patients. Depending on the lab, less than 1% or less than 2%, depends on the lab. These are the people who are at risk for spontaneous life or limb threatening bleeding with little or no trauma. Moderate patients have some detectable 1 to 5%, and many of these patients may have very little spontaneous bleeding, but with trauma, they will bleed. And then milds we may never see, because depending on whether it's an 8 or a 9, they may actually, they bruise more easily, but it's like not a big deal. And it's not unless they're in a surgical situation or in a real traumatic situation, or there's a family history that they walk in my door. Next paragraph. Next slide. And this just goes through more in terms of the severity and the different presenting symptoms. Generally speaking, we identify our severes within the first few months of life. And as you all know, bleeding is the main symptom. Most of those are joint bleeds. 10 to 20% are soft tissue bleeds, and 5 to 10% are what we consider life-threatening bleeds in the brain, in the neck, the throat, GI bleeding. Next slide. There's a new vocabulary word. Well, it was new. It's probably not new anymore, called a bleeding phenotype. We used to think a lot of things, but we used to think that if you were a moderate, you were not going to have any bleeding issues. And if you were severe, you are going to be having very, very frequent bleeds. Well, we now know that there's probably a gazillion other genes involved with all of this, plus environmental factors. And we now, all of us have recognized that we have moderate patients and maybe even mild patients by the numbers who bleed very frequently and may require interventions like prophylaxis, where I can tell you 30 years ago, that was not what we were doing or even considering. All of us have severe patients who really don't seem to be bleeding very much. And this is where doing things like the musculoskeletal ultrasound becomes very important for looking to see very clearly in the joints whether or not there's been any of this subclinical bleeding. Next paragraph, next slide. Sorry, I'll get it by the end of it. Next, and also hit it again, please, Greg. Okay, so no, go back. Go back. Go back. See, they're building now. Look at this. Okay, go one more back. Okay, so factor 8 has many roles. Try hitting it again. Sorry about the technology. Factor 8 doesn't just have a role in blood clotting. And this just shows you all the different things that factor 8 has a role in: inflammation, bone health. And this on the right-hand side is going to show you the different parts of the factor 8 gene, which we believe are involved with all these different things. Why does it matter? Well, it's important to know that factor 8 is doing more than just filling in that gap. And it does raise a question, which we do not have an answer to, is as we move into an era where perhaps some of these non-factor therapeutics are being used, what's going to happen to some of these other jobs of regular factor 8 if it's not being used? We don't have an answer to it. It's just something that we're constantly thinking about as a treating community and looking at to see if there's any impact. Okay, next slide. This is based on the 2015 census. I'm hoping to get numbers from the 2020 census just to show you in the United States where our population of hemophilia patients, hemophilia A, lies. And I'm sure the numbers are somewhat different. The one thing I want to point out to you is look at the age 45 plus. You have a large number of patients in that young adult age, right? 20 to 44. For all of you who are 43 and a half, congratulations, you're a young adult. But why? And the answer to that is the HIV and the hepatitis C epidemics back in the 1980s and 1990s. We lost a generation. And our adult treaters are now experiencing and developing the tools to take care of an aging hemophilia population, because for a while we didn't have very many. Next slide. And as we all know, this is expensive. And this just shows you a little bit of a breakdown in terms of annual costs. Again, this is probably somewhat outdated, but it gives you an idea, right? If you're on demand and you're a mild patient, your costs are less than if you are a prophylaxis patient. And this can run into the hundreds of thousands of dollars. And I'm sure all of you have shared our frustration with prior authorizations and justification. And I guess the one thing I can say is please maintain your bleed logs. Even if all you're doing is checking off that you have taken your factor or taken your bispecific antibody or whatever it is that you're using, because the insurance companies, at least in Florida, demand that on at least an annual basis in order to fill the prescriptions. So just an FYI. Next line. Next. Okay, so how do we diagnose it? I'm sure everybody in the audience has their own story. What's important is that in 1/3 of diagnosed cases of hemophilia, A or B, and also von Willebrand's disease, we never find anyone else in the family who has it. This is what's called a de novo or spontaneous mutation. When we are developing embryologically, there are genetic changes that are happening in our cells all the time when they're dividing. And 30% of people with hemophilia, that change in the genetic recipe happened spontaneously while that person was developing. The most accurate way to determine if if the mother is a carrier for the gene is to do gene sequence analysis and genotyping. And I would refer you back to your Hemophilia Treatment Center to talk about that, whether that is or is not indicated. The classical presentation for severe hemophiliac is the prolonged bleeding from circumcision. I think in the last 30 plus years, I've seen that maybe half a dozen times. More commonly, we see kids being referred from the emergency room, rule out child abuse, they have big lumpy bruises. Or I've got somebody who was a NICU baby, right? And somebody did a venipuncture or an arterial puncture and they present with a compartment syndrome. One thing which has happened increasingly, and I'm not quite sure why, we've gotten a flurry of new babies, and the signs, the warning signs in the regular nursery were missed. And this is important for those of you who do not have, or if you know of somebody who is having a baby. I mean, all of you probably now would go into a labor and delivery situation and your OB would know, and the pediatricians would know. But if there's no family history and you've got a baby in the newborn nursery and they've got a large collection of blood, a cephalohematoma under the skin of their scalp, or they have prolonged bleeding from heel sticks. And I'm talking about, I have to change I just had a mother like this last week. You know, I just didn't think that, I figured they knew what they were doing, but I had to keep changing that heel stick Band-Aid every hour, and it was just soaked, you know. Or another one of the vitamin K injections that the kids all get, right? And it's an intramuscular injection, and it became a huge bruise. We're seeing a lot of that, and that can lead to a problem. So again, if you don't have a family history, just be aware. And if it doesn't look right to you, say something. And certainly if you've got a family history, absolutely be on the lookout for something like that. What are the studies? Basic studies can be done by anybody, right? This doesn't require a special coagulation lab. If you've got somebody with unusual, an infant, a toddler with unusual bleeding or bruising, CBC. which has to have a platelet count. There are lots of reasons why people bleed. You don't want to miss other things like a platelet disorder or a malignancy of the bone marrow. The PT, as we pointed out for hemophilia, it should be normal, right? That's factor 7. And the APTT is going to be prolonged. And how long is long? We don't even go there because it can be all over the map. Bottom line, if it's long, your healthcare provider, wherever you are, needs to call hematology so that there can be an evaluation in terms of factor levels. Next. What about cuts and lacerations? Well, actually, in order to manage road burn, right? You skinned your knee, superficial cut, you don't need factor for that. That falls under the category of needing platelets. And again, hemophilia patients should have normally functioning platelets. And oh, by the way, that's the reason that we tell our families with bleeding disorders, if you can all avoid aspirin, Advil, ibuprofen, Motrin, these are what's called the NSAIDs, the non-steroidal anti-inflammatory drugs. Please use Tylenol for fever, for headache, whatever. Why? Because all of those other medications will interfere with platelet function. And if you got a problem with your factors, you want your platelets to work just fine. So superficial cuts and abrasions don't need anything other than pressure and normal first aid. But if you need suturing, or if you've had head trauma, then you're going to need to go the route of an infusion of factor. Next slide. Mouth and nose bleeding. This is usually much more of a problem to see for patients with things like factor 7 deficiency and von Willebrand's disease. And it's not as big a problem with hemophilia patients, but if anybody has ever owned children, regardless of their bleeding disorder status, you know that they'll fall, they're learning to walk, and they're going to tear those thin membranes that tether the tongue to the bottom of the mouth or between the lips and the gums. And those things bleed like stink in anybody. So that is something which, as a post-traumatic event, we're concerned about. Certainly for dental procedures, please let your HTC know that you're going to be having wisdom teeth extractions or you're going to be going to the dentist for deep cleaning. Do not call from the dentist chair and say, what do I do now? Because we need to work with the dentist to make you safe to go through the procedure. Interestingly, tooth eruption and exfoliation, if it's left to normalcy, patients, even severes, don't bleed because the pressure of the tooth coming up through the gum is usually enough to squeeze off those blood vessels. But when you're 6 and you want that loose tooth to come out so the tooth fairy can come in, you're wiggling it like crazy, that's when you're going to run into a problem with having some bleeding if they rip it out before it's ready. And nosebleeds, again, this is just to demonstrate the right way to stop a nosebleed. Everybody needs to know this, okay? I make sure that every one of my patients, whether they're sickle cell, whether they're an oncology patient, I don't care. They don't walk out of my clinic without knowing how to stop the nosebleed. You bleed from the front part of your nose 99% of the time. You want to put pressure in the front of the nose. You don't want to squeeze the bony bridge. You don't want to put ice on your forehead. You don't want to tip your head back, okay? I tell the kids, look at your shoes, squeeze the front and talk like Donald Duck for 5 minutes because they're putting pressure where it's bleeding. And I said, you have my permission, and mom hears it, that you can sing, tell jokes, do whatever. As long as you're talking like Donald Duck, we're good. Okay. And in general, that's enough to stop the bleeding or at least control it until you can move on to the next phase. Why head down? Because you don't want to swallow the blood. Blood is an irritant. It'll mess up your stomach and then you'll vomit up what looks like blood. And then everybody's going to be going crazy and taking you to the ER and calling the gastroenterologist and all this other stuff. And then there's lots of other things that we try to do. And again, I think you'll have access to this. Happy to talk about it, but let's move on because there's a lot to cover. And again, this is just something which we don't see very often. Today we would use ultrasound, but patients with severe hemophilia can have what we call a spontaneous bleed way in the back of the abdomen, a retroperitoneal bleed. People will present whenever we have somebody we're thinking about an appendicitis, we grab an ultrasound. We want to make sure there isn't a hematoma in one of the muscles. This is a non-surgical emergency. It requires bed rest and round-the-clock factor for weeks, and it can take a while for the patient to regain complete resolution of this. And this is where in our clinic, at least, point of care ultrasound becomes very important for actually following the progress of this bleed. Next slide. Now, you can see soft tissue and muscle bleeding can be a big deal. Everybody learns how to walk, everybody falls, and you can get a butt bleed. And a butt bleed may not show up for a while, that you can see, right? Because there's that padding, especially if your mom is feeding you very well. And it can take a while for it to show up. However, what happens with these large bleeds, a child may not be sitting fully on his butt, right? He'll be on one cheek. He may be limping. And if you feel his buttocks while you're bathing him or you take him to the pediatrician, you may feel what sounds like a rock hard mess. These large lumpy hematomas on the front of the legs, the thighs, whatever, they heal by the deposition of calcium, and they can feel like a malignancy. I've had 2 patients who were referred to me to rule out a muscle malignancy, and it turned out that they were undiagnosed hemophilia patients who had fallen on their butt. You can see the other slide just shows you what happens with an intramuscular injection deep into the muscle, and you can have what's called compartment syndrome, where the pressure just builds up and becomes much more of a problem. We try to avoid IM shots as much as possible. Our immunizations are administered as what's called a deep subcutaneous injection, and we provide pediatricians with instructions how to do it. We do not pre-treat immunizations with factor. However, when we're talking COVID vaccine, talk to your healthcare provider as to whether or not he feels or she feels that before you go to get the COVID shot, you should have an infusion, just as an FYI. Next slide. And again, you can see if this child or this adult in the far right showed up in the emergency room, you'd have to worry about abuse. And we as healthcare providers are mandated to make a report, but as we teach our trainees, even if there's no family history, grab that PT, grab that PTT in the CDC. You got to make the phone call. You got to explain it to the family, but you can't necessarily say it's not a bleeding disorder. Next slide. Again, just shows you more pictures. This is a woman who has von Willebrand's disease on the right. You can see that's kind of worrisome. Next slide. Normal bruising occurs mainly on the legs. There's obviously no family history. The rest of the physical exam is fine. There's no other signs of bleeding, and the lab panel is normal. Next slide. A child who presents with bleeding or bruising concerning for abuse should be evaluated for an underlying bleeding disorder, but the presence of a bleeding disorder does not rule out abuse, and the presence of trauma does not rule out a bleeding disorder. Any bruising in a non-mobile child is highly suspicious for abuse. But you could see on the previous slide, many of you may have had the experience, you're just picking up your son, and then a few hours later, you see that there are thumbprint bruises along his rib cage. Well, that's not abuse, obviously. But again, if you go to the emergency room, you need to be prepared for that. Next slide. And a nod to probably more than 50% of the people on this conference, women do have bleeding disorders. And I'm sure you all have your stories, right? No, it's just normal for me to have a period that lasts for 2 days. Every woman is iron deficient. It's just the price of being female. I can't tell you how many times I've heard that from healthcare providers. NHF estimates that 1 million women and girls in the United States have a bleeding disorder, but maybe only 20,000 know about it. And von Willebrand's disease is the most common bleeding disorder worldwide. Women who carry the gene for hemophilia A or B may or may not have low factor levels, may or may not have bleeding symptoms. They may qualify to be called a mild hemophiliac. Talk to your healthcare provider. And this is probably one of the biggest things that we're fighting with right now, is the concept that a woman who is a carrier may have symptoms and low factor levels and need care through a hemophilia treatment center. Next slide. Joint bleeding or hemarthrosis is the most common complication of hemophilia. 45% of severe hemophiliacs will have their first joint bleed within the first year of life. 90% of severes will have at least one joint bleed by age 4. And what we are seeing is that even with prophylaxis now, and we're now into that generation that grew up with prophylaxis, and now they're young adults and they're in their 20s and their 30s, and they were fine. But now we're finding that they have signs of arthropathy in at least one joint, even by the time they're 25. So we have to do better. And again, this is where utilizing new technology such as the ultrasound will become extremely important. Next slide. And these are the joints which are most commonly involved. They're the synovial or ball bearing joints, shoulder, elbow, hip, knee, and ankle. The ankle is now the most frequently and first joint involved. And repeated bleeds in a particular joint leads to a target joint, which can go on to the development of arthropathy and bony changes. Next slide. And many of you are very familiar with this. Top shows you an acute bleed, right? It's swollen, it's hot, it's painful, it can be red, and you can't extend the joint. It's kept in a position of flexion. So why is it flexed? Just as an FYI, the joint space is very small. And as fluid of any kind fills the joint, the fluid presses on the nerve endings that run through the lining of the joint, and it hurts. By holding a joint in the position of flexion, you are maximizing the space in the joint and easing some of that pressure. So that's why you may find that a child with a knee bleed isn't going to extend it, right? Or is not going to reach if he's got a shoulder bleed or an elbow bleed. And the lower slide just shows you what we try really hard to avoid, which is a chronic target joint. The joint is in a permanent flexion contracture. There's persistent diffusion, synovial overgrowth, and what we call disuse atrophy of the musculature on either side because he can't use that limb. Next slide. We all know what acute joint bleeding will cause: pain, time lost from school or work, caregiver and patient anxiety and stress, ultimately disability. Next slide. And long-term consequences. You're also familiar with the target joint development with joint destruction, chronic pain, and certainly a markedly diminished quality of life. Depending on how much time somebody's lost from school, that may impact his or her career choices as well. Next slide. How many bleeds does it take to damage a joint? I'm not reading all of this. The answer is we have no idea. Next slide. Some patients only have 1 or 2 bleeds, and yet that joint is gone. Some patients can bleed frequently, and they seem to have no residual effect. So the answer is we work very hard to prevent any joint bleeds. And the World Federation paradigm is treat, replace deficient clotting factor. And we will talk a little more about that. Prophylaxis is now the standard of care, ideally starting between 1 and 3 years of age. Lifelong treatment is probably required. And this is probably critical for those of you who find yourself in a situation where you are far from home. If you have an injury or a bleed or an accident and you go someplace else, treat first and worry about the consult, the imaging, everything else later. Once you infuse, depending on the product you're using, you've bought yourself a window of hours, maybe even days, where your blood clotting profile has been normalized, and then there's all the time in the world. And this is how we teach anybody that comes within sniffing distance: treat first. You're not going to hurt somebody by giving them a dose of factor, but you are going to hurt somebody by withholding. Next slide. And you all know the real world benefits of prophylaxis, right? It decreases, it improves joint health. It decreases the morbidity or the potential for damage from surgical procedures. Patients on prophylaxis can live relatively normal lives. They can participate in sports. They're more likely to maintain long-term employment or consistent school attendance. And it's never too late to start prophylaxis. I hear this a lot. My adult counterpart hears this a lot. Nah, I'm 65 years old. My joints are shot. I just don't want to start doing this anymore. I mean, I've made my peace with my hemophilia. Now, this is how 30, 35 years ago, we would tell families of newly diagnosed severe hemophiliacs, you have to be prepared for the fact that your child is going to have bleeds. And we still say that because kids are kids, right? But it's the reality that we now know what we can do to prevent that, or to prevent it as much as possible, because anybody who goes bungee jumping or slides off a mountain is going to bleed. I don't care whether you have an underlying bleeding disorder or not, right? We can't control that. But in terms of the spontaneous bleeding, that's where the prophylaxis comes into play. And for our adults who are resistant, many times we'll say, why don't you just give this a try for 3 weeks? See how you feel, because it's been well shown that even with well-established target joints, prophylaxis can cut down on inflammation, can make things feel better, and maybe make things move a little bit better as well. So primary prophylaxis starts from infancy, anywhere from 1 year to 3 years of age you start, and secondary can begin at any age. And usually at that point, there's been a history of treatment. Next slide. Nod to DDAVP. This is a synthetic form of the hormone that our pituitaries make to regulate salt and water balance. It is very effective for patients with type 1 von Willebrand's disease, as well as mild hemophilia A, because the factor VIII, which lives attached to the von Willebrand's protein, is stored in those cells which line the blood vessels, the endothelial cells, and under stress conditions, and injury and surgery certainly count, it can be released into the circulation and get to work. There are limitations for how it can be used, when it can be used, and just as a nod to the reality of it, up until the beginning of the pandemic, it was available as a nasal spray, but there's been an international recall of that, and we don't believe that that nasal spray, which was marketed as Stimate, is going to be back on the market until maybe 2024. You can use DDAVP intravenously. You can use DDAVP as a subcutaneous injection. Again, this is a conversation if you have mild hemophilia A or von Willebrand's disease with your healthcare providers to find out, can this be something which is useful? Again, because it can be given subcutaneously, but there are limitations. Next slide. And when you go to an emergency room, what do you need to make sure that your ED physician needs to know, assuming that you are not in your HTC's ER? What kind of hemophilia do I have? Do I have an inhibitor? What kind of bleed is it? Is it a major bleed or a minor bleed? What does that mean? What is the factor that you are using? How many units do you use? Do you have your factor with you? When did you take your last dose? Who's your hematologist? This is information that you need to make sure, even if the ED physician isn't asking, that you can present, okay? And MASAC, the Medical and Scientific Advisory Council of National Hemophilia Foundation, has guidelines for the management of bleeding disorders patients in the emergency room, and that's guideline number 257. Next slide. Inhibitors are the most serious complication of hemophilia today. This develops in 20 to 30% of severe hemophilia A patients, also develops in severe Bs, milds and moderates. Just as an FYI, this is a protein which some patients develop after exposure to clotting factor concentrate, and the inhibitor basically blocks the efficacy of the factor being infused. We usually screen our patients at least annually for the presence of one. Tip off, if you're used to using a certain regimen to manage a bleed and it doesn't seem to be working, the bleed is getting worse, call your HTC. Make sure that your child, your husband has not developed an inhibitor, okay? If you're going into a surgical situation and the surgeon makes sure that you get your dose of factor pre-op and checks that PTT and it hasn't corrected, call the HTC, get them involved, because that is the possibility. We know that there are certain genetic mutations which predispose. We know that the inhibitor development is higher in African American and Hispanic patients. So again, talk to your HTC. Next slide. Obviously, there are unique challenges if you can't use the factor that you've been using all along. There are bypassing agents, factor 7, activated factor 7, and FIBA, activated prothrombin complex concentrates. They are effective. We don't know which one's going to work for a particular patient. There are challenges involved with both of these. Again, talk to your HTC. Next slide. And this just shows you the issues involved with having an active inhibitor. Patients' outcome and quality of life are definitely negatively impacted. Next slide. And it's much more expensive as well. We do use the the bypassing agents in a prophylactic setting for our inhibitor patients, but it's extremely expensive. And again, there's a lot that goes into making that decision. How is it used? How often? How effective are we going to be able to monitor that? Next slide. There's a very simple test that can be done. It's not just sending it to the lab to do an inhibitor titer, which can take a few days, but it's taking that PTT, which is prolonged, and mixing it in the lab with normal plasma. And if it corrects, it just means that the patient is deficient. But if it continues to be long, it's worrisome for an inhibitor. Next slide. And there is, and I'm going to skip through the next few, but there is an entity called acquired hemophilia. These are people who are not hemophiliacs, and then they show up usually as adults in an emergency room with a prolonged PTT, profuse soft tissue bleeding, and everybody scratching their heads. And all of a sudden you've got a 64-year-old woman and you're going, oh, well, she has hemophilia. She has a PTT of 120 and her factor VIII is 6%. So she must have hemophilia, even though for 64 years she never had it. And this is, again, just something to be aware of. Many of these adults will have an underlying problem, either an underlying autoimmune disorder or an underlying malignancy that hasn't been identified. And again, hematology has to be involved. Next slide. And next slide. And next slide. And next slide. Okay, so when you have an inhibitor, you have two problems. I want to stop the bleeding, and I want to try to make the inhibitor go away. And stopping the bleeding, again, this just shows you that clotting cascade using these bypassing agents, which are highlighted in red, as a way of avoiding the need to give factor VIII or factor IX. How do we make it go away? There's something called immune tolerance induction, where patients are given high doses of either factor VIII or factor IX daily, twice daily, with or without immune suppression, medications like Rituxan, to try to get rid of the inhibitor. And then that can take months to years. It's expensive, it's venous access issues. And once you have, if you are successfully what we call tolerized, meaning the inhibitor has gone away, you can use your factor VIII or factor IX, but you are at that point on a prophylactic regimen, whether you were before or not. Next slide. Recombinant porcine factor VIII from pigs has been useful in patients with acquired hemophilia A. Next slide. And we have barriers to current treatment regimens, right? Adherence to prophylaxis, it's a big deal. If you've got little kids and you're chasing them around the house at 6 o'clock in the morning to give them their factor, that's always a lot of fun. But it's more than that. It's a commitment of time. It's a commitment of energy. And again, you're having infusions, right? The impact of inhibitors is a real unmet need, and the limitations of treatment as well. We're still seeing joint disease now in our young adults. Next slide. You're familiar with standard half-life factor concentrates, and now the extended half-life factor concentrates have come out into the market. Many of you may be using those to give you more time for that factor to exist in the circulation. Here's where factor VIII and factor IX are different molecules. The extended half-life factor IX products may allow our patients to infuse once a week, maybe even once every 2 weeks, sometimes even up to every 3. The factor VIII products may allow, and this requires testing and discussion, may allow patients to infuse every 4 days, maybe every 5, instead of every other day or 3 times a week. Remember that children, especially under the age of 6, they're not little adults. You all know that in many ways, but physiologically, they're not little adults. They clear medications out much more rapidly, regardless, than do older kids and adults. And this becomes an issue sometimes with third-party payers when we need to use a higher dose and it's not the label, and what are you doing? Again, we spend a lot of time doing this. This is a very burdensome situation for our families. Next slide. Okay, so what's new? Many of you are familiar with emicizumab. Brand name is Hemlibra. Remember that slide that we were having trouble with, which showed all of the different functions of factor VIII. Well, now we focus on what does factor VIII do for coagulation. Factor VIII serves as a bridge, I call it a matchmaker, between activated factor IX and clotting factor X, going back to that clotting cascade. So the emicizumab has a binding site, it's called a bispecific antibody, right? Has a binding site on two sides for two different proteins. And it brings activated factor IX close enough to factor X to turn factor X on, and then the rest of the common pathway, right, the one that leads to the formation of fibrin, proceed. Again, I call it a matchmaker. Next slide. The emicizumab is a subcutaneous medication. It is for prophylaxis for hemophilia A patients with or without inhibitors. It can be, everybody gets once a week for 4 weeks, and then you talk to your healthcare provider. You can get it once a week subcutaneously, every other week subcutaneously, or once a month subcutaneously. It is for prophylaxis only. If you have a breakthrough bleed, if you're going for surgery, talk to your HTC team. You will need factor to manage these things. You don't stop your emicizumab, that keeps marching through on whatever your schedule is, but you may need factor to cover these on-demand situations. When you go to the emergency room, unless it's your HTC emergency room, I guarantee you people are going to look at you and go, what the heck is this? And they're going to say, oh, did you bring it? Because we're going to give you another dose of that, because that's how we've been trained, right? Give another dose of factor. This is not factor. You do not get a double dose of that. The other thing which is important is to know that standard clotting tests are going to be completely inaccurate if you are on emicizumab. Those numbers are going to be off the wall. And I can't tell you how many phone calls I get from hysterical community ER people. Oh my God, the PTT is 4 and the factor VIII is 350%. You know, so again, you're your own advocate. You need to understand this so that you can share with the healthcare team in the ED or the urgent care. We provide our patients with a travel letter, which says, this is me, I'm taken care of here. This is the medication I'm on. If I'm in your ER, this is what you need to do. I am quite sure that your HTCs will provide you or do provide you with the same. Next slide. The one thing with emicizumab for our inhibitor patients is the fact that if you have a breakthrough bleed and you're an inhibitor patient on emicizumab, you cannot use the activated prothrombin complex concentrate. That has to be under the direction of your HTC because of the clinical trials, and we're also smart now about clinical trials and adverse events, right, with all the COVID stuff. But there were a small number of patients on the clinical trials with inhibitors who got a fair number of doses of the prothrombin and the APCC and developed significant clots. So if you are going to be using it, that has to be under the direction of your HTC. Otherwise, recombinant factor VII is what we use for breakthrough bleeding. Next slide. There are other things in development looking at different ways of working with or enhancing clotting or preventing clot breakdown. These are all in development. These are subcutaneous as well. Next slide. Hot topic, gene therapy, right? What is it? Where are we at? What is it going to do for me? Basically, if you have a mutation or a change in the genetic recipe for your factor VIII or factor IX, common sense is let's fix that gene, okay? And then I have no problem. Well, how do we go about doing that? Next slide. Gene therapy has been around the first idea came up like in 1972. Somebody said, hey, this might be a good idea. And I believe it was with cystic fibrosis that a lot of the early work was done. There are no gene therapy trials which are approved for use in factor 8 or factor 9 deficiency. None. They're in development, but they haven't been approved. There are actually only, there are a handful of gene therapy products or protocols. One is for a retinal disorder. One is for something in toddlers called spinal muscular atrophy. And there are a couple of different ones for oncology protocols. But other than that, there's nothing out there. It was in 1999 that a factor 9 gene therapy protocol was started, but was pulled fairly quickly because of a serious adverse event. And in 2005, it started up again. And in 2015, the first gene therapy trial for hemophilia A started. And again, nothing is approved. Next slide, next slide. So what are we using? It's called it's called gene transfer therapy. There are lots of different techniques for gene therapy. It would be great if we could cut out the bad gene and put in the good gene. And that is called CRISPR. And that is under investigation for oncology protocols. And maybe at some point, and I think for sickle cell, maybe at some point it will be applicable. But right now we're using viral vectors. Why viruses? Viruses get into cells. That's what they do. And they've been used a lot. So what happens? So scientists will take a virus. A virus is basically a shell or a bag holding the viral genetic material. And that's what makes you sick, right? When the virus actually gets into your cell and into the nucleus of your cell, and the viral DNA gets into your DNA and takes over, that's when you get sick. Well, so what scientists are able to do is they're able to empty out the viral genetic material. And obviously this is all done in the lab, this is all synthetic, and it's left with this bag or this shell. And the shell itself is harmless. And then they bioengineer a normal factor 8 or factor 9 gene. They introduce it into this transport molecule, right? This neutralized viral shell. And then it's given to patients who are eligible for this through an intravenous infusion. The viral shell is very smart. And the genetic material which has been created, which is the factor 8 or factor 9 gene with a couple of other pieces on it to kind of guide the boat and help it package and unfold. It's selected to go to where factor is made, which in the case of factor is the liver. And this is called the tropism of the virus, right? So it'll get in, you're infused, and it knows where to go. And there are a lot of different viruses which are under investigation. This nice little graphic shows you, AAV viruses, adenoviruses, lentiviruses. They all have different properties. They may carry they may carry larger or smaller. The ones which are being used for gene transfer therapy right now for hemophilia are the AAV vectors. This is a virus which in the real world does not make people sick. Problem is many people may have been exposed to it anyway and have developed antibodies against the viral shell. So it's a whole big process to determine if somebody is eligible for one of the gene therapy trials. Next slide. And this is just fancy, right? It just shows you what it looks like. Next slide. And again, these are just different techniques. They're not applicable for everything. Next slide. Okay, so if you are over 18 and your HTC participates in a gene therapy trial and you think it's something of interest for you, talk to your HTC team. One thing which is important to realize is that with these gene transfer therapies, the normal factor gene does not incorporate into your own cell's DNA. It exists outside of that, and therefore your own genetic makeup stays the same. So that gene therapy, if it is helpful for you, which will translate into your body will start manufacturing more factor 8 and probably cut down on prophylaxis or eliminate it or whatever. you're still genetically going to pass that gene on to your daughters. It doesn't fix that. So just to be aware. So where are there some other challenging issues? I know I tend to talk a lot. How do we manage newborns with hemophilia? The big deal that we worry about is the potential for intracranial bleeding. We urge our families, please tell your OB that you have a hemophilic son. Now, what if you have a mother who there's no family history? You haven't done gene sequence analysis on mom, so you don't know if she's got the mutation. She only has one hemophilic son. There's no one else in the family. And now she's pregnant again with a boy. The guidelines say that this is a woman who should undergo an elective cesarean section to avoid the risk of intracranial hemorrhage to the newborn as he is born through the birth canal. Now, hemophiliacs have been born for centuries that way, but it comes down to, do you really want to take that chance now that you know? Again, lots of discussion. There are certain common sense things. And I've had mothers who have just been, I'm not doing it unless there's a problem with the baby, and for that reason. Okay, I mean, as long as the OB has the information, as long as the delivery room nurses know, as long as the NICU nurses know, there's a limit as to how much you can make somebody, that's a bad word, do what seems to make sense to me, right? It's what makes sense to everybody, and particularly the families. But in general, we advise the avoidance of fetal scalp electrode monitoring, which has been done in various situations. Also, if it's an instrumented vaginal delivery, that's no. Forceps, vacuum extraction. And we make it very clear, and the families agree. If it looks as if there's going to be a need to use forceps or some other manipulation, then they'll switch over to a cesarean section. Once the baby is out, pay attention to those heel sticks and avoid arterial punctures, as well as blind sticks, because you want to avoid a compartment syndrome. At delivery, cord blood should be collected for a factor assay. We spend a lot of time talking to labs, because a lot of our moms don't deliver in our house. You know, with the OB, with the neonatal people, with the pediatrician. I mean, the main idea is grab a light blue top tube. They're doing a whole lot of blood work anyway from the cord, and send it off, because depending on the situation, within, if you're at my place, within a few hours, you're going to know if that newborn is affected. Otherwise, if it's going to go out to another lab, the baby needs to be managed as if he or she doesn't, is managed as a hemophiliac. I see that there's a chat, our cord blood wasn't accurate. So for hemophilia B in particular, all people are born deficient in clotting factor 9. Factors 2, 7, 9, and 10 are what we call vitamin K dependent factors. Babies get vitamin K in the delivery room because they're vitamin K deficient. And there is an entity which, before we knew about vitamin K, there was a lot of newborn bleeding episodes and death because they didn't have enough of these clotting factors. So it is very possible that your factor 9 level, and even your factor 8, but more your factor 9, is going to be low, but then later is going to turn out to be somewhat higher, or maybe even normal, and there are normal ranges. Another issue is for kids who are moderate hemophiliacs, the stress of the delivery. Remember, I talked about DDAVP, right? And how under stress conditions it can be dumped out. Well, the maternal hormones, the estrogen in particular, which crosses the placenta, plus the stress of delivery, which is stressful for the baby as well as for the mother, can cause this release reaction. So if you have a baby who is a moderate or mild factor 8, their newborn cord level may actually be higher than what it turns out to be because of this dump out reaction to the stress. So we've had kids who the cord blood is, 7%, 8%. But we always bring our kids back when they're 6 months of age or a year of age. And we repeat that level. We want to know where they've settled out at. So I'm not sure what the inaccuracy was. And obviously there's always a problem. Did they fill the tube enough? Was it a good specimen? How long did it take to get to the lab? I mean, there's all this other stuff. But if there's a discrepancy, then find out where people think it happened. And you can always repeat when the baby is older to be able to get a more accurate picture. Next slide. Okay. And again, we do a lot of talking to moms, right? Next slide. And again, we do a lot of talking to the OBs. The bottom line of it is that you need to have a plan in place. And if you're not going to be delivering at a center which has a hemophilia treatment center, there should be a liaison. There should be a way of communicating so that your OB is not left scratching his or her head, and you and your baby are not left in a situation which is a problem. Ideally, you should be an ATC. That doesn't always work out. Next slide. Next slide. Again, I'm very glad I'm a pediatrician, but I do know that as the population of hemophilia patients ages, there are other challenges, and some of it has nothing to do with hemophilia. But it is something that my adult counterpart has to balance, because seniors get thromboses. There's an increased fall risk for all of us as we age. Well, that's not a great thing if you are a hemophilia patient. Inhibitor formation goes up as we age, and we're seeing that in moderates and milds. So there's a lot of juggling when you reach the glorified age of 21 or 22. That doesn't excuse you from continuing on with your hemophilia treatment center, because more things will come up. Next slide. And has there been a change? Well, you all sitting here are living proof of it. In the 1960s, a person with hemophilia worldwide could expect to live less than 20 years worldwide. That includes this country, that includes Britain, that includes Japan. People were experiencing severe disabilities by their early teens due to crippling joint disease. And it was a life defined by pain and limited opportunities. They weren't going to school, they weren't playing sports, they weren't getting married, they weren't doing all this stuff. By 2020, and I need to change this slide, in the developed world, the average life expectancy is now normal. There have been no serious bloodborne pathogens identified since 1990, and there are many places which are now using plasma-derived products, and in von Willebrand's certainly using that. And there have been no seroconversions since the 1990s. And every time I say this to a group of healthcare providers, there's like this, really? I thought everybody got AIDS from contaminated factor. It's like, okay, well, that's why we give these talks. And serious joint disease really is virtually non-existent in hemophiliacs under the age of 15 if they have no inhibitor. And today, with the use of this bispecific antibody, that has been a significant game changer for our inhibitor patients as well. Next slide. You all are familiar with comprehensive care. We rock. Next slide. It's been clearly shown through CDC studies that patients who have even a once-a-year visit in a comprehensive hemophilia treatment center will have significantly less morbidity and mortality. Next slide. And just as an FYI, one of the issues I've run into with community physicians is I don't want to give you my patient. I don't want to lose my patient. A once-a-year visit at an HTC, we're not taking over, but we're there as a backup for when there is the weird surgery, right? Or there is the problem. You're in the system. Or maybe there's something new coming down the pike. We're opening up a study. We're not trying to take you away from the hematologist or the internist who has served you so well for so long. We want to be a partner, and we want to amplify your experience. So NHF, you're probably familiar with, has this absolutely amazing book called Playing It Safe. They rank activities in terms of safety, in terms of the potential risk for joint bleeds or for intracranial bleeds. I will tell you, our physical therapist has a book like this, and in it is every single sport and every single position in it, and every single joint that is impacted. And when we have a guy who comes in and he decides that he wants to do, I don't know what, she'll sit with him and she'll say, well, let's take a look at what your risk is by participating in this activity, understanding, of course, you're going to use appropriate protective gear, and you're going to follow whatever your regimen is as prescribed in terms of factor or bispecific antibody, whatever it is. Let's look, is there another position that might be better for you since your shoulder's a mess kind of thing, or you tend to have knee bleeds? I mean, it's really amazing what is available right now and how different this world is from when I started the program 30 plus years ago. I was 5, but I started it 30 plus years ago. Next slide. The other thing that we have learned is that this is not a cookie cutter process. It used to be. If this, then this, if this bleed, then this. I hope that we as a community are doing a lot more asking and a lot more listening. And I hope that you, as a patient community, are doing a lot more asking and holding us accountable when we're saying something which may not make sense. There's something you want to be doing. There's an activity you want to be doing. There's a goal that you have. Talk about it. Let's see how we can make it work. Again, there are going to be a few things which are just not going to be possible, but literally the possibilities are limitless compared to what they were. Next slide. And I thank you for your attention. I am definitely happy to take any questions. By the way, yes, thank you for that. This is the link for the evaluation. And it's going to be in the chat box, and I believe Sue's going to be sending this out as well. Again, thank you, everybody. I hope you have an awesome rest of the meeting and stay safe.